Alright, so we're going to talk about some of the specific syndromes that tend to cause elevation while not having an ischemic cause here. And we've talked briefly about a lot of them, but there's some real common ones, there's a few less common ones, and then there's a few that are kind of out of left field, but they're all pretty important. Alright, LVH, maybe the most common, certainly among the top 2 or 3. According to that one study we looked at, they think it's the single most common. Now, it doesn't always cause ST changes. When it does, we call that a strain pattern. It's just an effect of the myopathy in the heart. When it does cause these changes, Scarbosa criteria work quite well. And you really want to use that modification of proportionality. Don't try to say, well, more than 5 millimeters or anything like that. Look at the size of the waves, and then look at how much elevation you have relative to that. Now, in some monitors, this can be hard to judge. Zoll monitors, in particular, tend to cut off very large waves. So if you have a deep S wave, which shoots down maybe 6, 7, 8 large blocks, you're not going to see most of it. It'll trim off the end of it. And you can tell because instead of coming to a point, as any wave normally should, there's a square edge to it. So you might be saying, well, I don't know how deep this really is. It's hard to tell exactly how much elevation I can have. That can be tricky. Life packs will do that if you're on the edge of the page, but in most leads they will just overprint, which can also be hard to read, but it's usually a little bit easier to work with. Now, one useful tip here. Dr. Smith has pointed this out. A true anterior STEMI, meaning you would expect it to cause ST elevation in the anterior precordial leads. It's almost never present when you also have obvious, really clear LVH on the 12 lead. And what I mean is, you print the 12 lead, you say, wow, we've got huge voltages in the anterior leads. Look at that deep plunging S wave, 5, 6 large blocks, very big voltages in V2, V3, V4. Is there also a STEMI? The answer is probably no. Why? Probably because when there is a truly damaged infarcting heart there, it cannot produce voltages like that. It's hurting. It's like if I asked you, could a sprinter with a broken leg run a world record 100-meter dash? No, probably not. He's injured. He can't do that right now. So Dr. Smith actually for a while was asking anybody who thought they had a true STEMI where you also had really clearly substantial LVH voltages to show him that. And I think he finally found 1 or 2, but it almost never happens. And what I mean is not if you go in and add up exact voltage criteria and maybe it barely passes as LVH, could there be a STEMI? Maybe. What I mean is when you see those obviously huge waves and you're saying, well, is there also a STEMI? Probably not. Now, we talked about concave ST segments. In a few cases you will see LVH that has a convex ST segment, and that can be okay. I wouldn't say it's common, but it does happen. If you were a cardiologist, you would be diagnosing LVH, perhaps with other diagnostics, but from the EKG you would do it by actually measuring some of these waves and adding up some voltages. There are a number of different criteria for it. Generally, we don't need to care about it because it doesn't matter. These principles, like appropriate amounts of discordance, they apply whether or not it happens to pass as true LVH or not. So don't worry about that. This is a nice example of LVH. And you say, oh, okay, we got nice big voltages. Now, is there a STEMI in here? Well, we're going to use discordance. Well, gosh, look at lead 3. We have a positive deflection and then positively deflected ST segment. There's elevation and then a positive T wave. So that's concordant. That's not okay. That's in 3. Let's look at the other inferior leads. Look at AVF, also inappropriate positive concordance. Maybe a little bit in lead 2 as well. Now let's look reciprocally. okay, AVL, that's not obvious, but the last deflection in that QRS is actually negative. It's right down there. And then right off of that, you have ST depression and then a negative T wave. So that's inappropriate negative concordance. And then the same thing in lead 1 as well. And we're seeing the same thing in maybe 2, 3, 4. So that makes me think, well, I think we have elevation on top of our baseline pattern in inferior leads and then depression in the anterior leads. That looks maybe like an inferior MI to me, or inferior posterior. And in fact, that is what's happening here. And you see the Marquette algorithm caught it. Acute MI suspected. It says LVH, which is true, and then on top of that, acute MI. So that's not bad. All right, left bundles. Now these are a can of worms. Remember, left bundle was originally what Scarbosa was trying to diagnose. So these are maybe among the top most common mimics of MI, and a lot of people are still taught that when you see a left bundle branch block, that's a non-diagnostic EKG, meaning you're just supposed to throw up your hands and say, we can't do anything with this, and you tear it up and you walk away and you don't say anything more. Or you're supposed to say automatically that we're going to treat it as an MI. Now, the reason you would call it non-diagnostic is because it's tricky to recognize an MI when there's left bundle branch block. So that's fair. We don't want to say that we're not going to try and help these people, because you can get a left bundle branch block which is caused by a heart attack. So the AHA has gone the other direction. They say if you see a left bundle branch block, which as far as we know is new, meaning the patient didn't have it a year ago and it was diagnosed, but it seems to be new, we're going to assume that there is an MI there. Now, why would they say that? Because when you have a left bundle branch block, which is due to an extensive acute myocardial infarction, they have a very high mortality rate. So think about what they're saying there. They're not saying that people with new or presumed new left bundle branch blocks are probably having an MI. They're saying that if they're having an MI, they have very high mortality. They're a high-risk group. Now, why? Probably because if you have a big LAD occlusion and it's proximal enough that it's endangering a very large portion of the myocardium, and it needs to be in order to compromise the electrical system. So if it's killing a large part of the anterior wall, it compromises the conduction of the left bundle branch block. That means it's a big part of the heart that's at risk, and that person may die or have really severe sequelae from that. So it's a risk stratification. Now, what the AHA doesn't say, but which we all understand, is that because it's hard to catch these MIs when there's also a left bundle branch block there, maybe we should just play on the safe side. So now a lot of us are taught now that if you see a left bundle, which is new to the best of your knowledge, we'll just treat it as an MI, and that is what the AHA wants you to do. Well, the first problem, how do we know if it's new? Well, maybe the patient knows if they had a diagnosis of this, and if they don't, then that tells us something, especially if they've been in pretty regular care. Maybe there are old EKGs we have access to, although good luck with that when you're in the field. And really, in the end, you usually can't. So that makes it a problem. Second problem, this is really the doozy. Even if it is new, or new to the best of our knowledge, even if we know that's true, it still should not tell us that there is an MI here. Now, this is one good study. This is similar to the one we looked at. It's a retrospective study of emergency department patients. They looked at all of their patients who actually did have, ACS type complaints, so chest pain or what have you. and they grouped them into people who had new left bundle branch blocks, those who had old left bundle branch blocks, and those who had no left bundle branch blocks. And they all had the same probability of actually having a heart attack. Meaning, whether or not they had a bundle branch block, whether it was new or not new or otherwise, had nothing to do with whether they ended up having an MI or not. So, if you have a left bundle which is new, and you're having an MI, presumably the MI is causing the left bundle, and that means that it's very bad, and that means that's a high-risk patient. But the presence of a left bundle is not itself an indicator that there is an acute MI. So you still need to make that diagnosis. If all you know is there's a left bundle, that doesn't say anything. And this actually is what you find out in the real world. Despite what the AHA has been saying about treating new or presumed new left bundle branch blocks as an MI, maybe some places were doing that initially when they first instituted that recommendation, but what they were finding was that these patients were having no higher incidence of actual occlusions in their coronary arteries than anyone else. So generally, this is no longer done. Most interventionalists are ignoring that recommendation. So this is just not really a concept which is holding water in the real world. And if you see these left bundles, I do not recommend that you assume it's an MI. That's not going to get you very far. So, how do we actually do this? Well, we know the main tools now. Scarbosa, it works well. That was originally what it was developed for. We know how to use it. It's great. Serial EKGs, again, work real well. A simple left bundle should be stable. It sits there, it doesn't do anything. Maybe the patient has chest pain for some reason. Maybe they're more or less asymptomatic, but it shouldn't be dynamic the way that MI will be. And maybe you can actually get your hands on one of those old EKGs. Remember, whether it's old or whether it's new, it really doesn't change the probability of MI. But if you have an old one, you can compare changes directly. So here's his old left bundle. Now we see that there's an increase in elevation or something like that. All right, right bundles. These are a little bit less famous, but they are up among the more common mimics. The nice thing is they're often easier to deal with. They usually don't cause ST elevation because right bundles should have a predominantly positive QRS, so appropriate discordant changes should be ST depression and T-wave inversion. So still changes, but depression, which is usually less alarming to us. Now, it's the same story as far as risk stratification. If you have an MI and it causes a right bundle branch block, that's associated with a lot of deaths and a lot of morbidity. Really the same deal as left bundles. So same concept there, but also the same concept that just its presence doesn't mean that there's an MI. So use the same principles. Scarbosa does work, although it was not validated empirically. Just remember, it only really works here if you base your comparisons against the terminal or the last deflection in the QRS. Because in the case of a right bundle branch block, that's going to be the positive R wave. If you're looking at something else, it may not be as clear. And the final caveat is we know that there will be some depression or T-wave inversion at baseline in a lot of these right bundles. Just beware that you don't miss changes that are actually reciprocal changes to a posterior STEMI, which would also cause ST depression. So look for maybe an increase from what you would expect to be your normal depression. Remember, use proportionality. So a certain amount of depression would be proportional. If you see a whole lot, maybe be concerned that there is also a posterior MI. Get those posterior leads if you need them. Alright, so take a look at this one. This is a right bundle branch block, and we're going to ask, is there also an MI in here? And take a look. We have, say in V2, we have a positive QRS, and there's ST elevation, so in the same direction as the QRS, and then an upright T wave. So that's concordant. We don't want to see that. Same thing in V1, V3, V4. So we're thinking, alright, those are anterior leads. Could there be an anterior MI here? Let's look reciprocally. All right, maybe in lead 2, 3, and AVF, we have a little bit of ST depression and an inverted T wave. So those are moving down, but the QRS is negative, so that's concordant. That's not appropriate. We don't want to see that. So those are reciprocal changes. So we look at the overall pattern and say, all right, that seems like maybe an anterior MI with reciprocal changes, and that actually is what's happening. And Marquette caught it, acute MI, with the right bundle branch block. All right, so RVH. Really not too much different from LVH. Obviously, it looks a little bit different pattern, but same story. Use your scarbosa, it does work. The only real differences from LVH, usually you mostly see it in maybe V1 through V3, often with a right axis. Again, just like with right bundle branch blocks, you want to keep an eye out that you're not going to miss a posterior MI with those anterior reciprocal changes. So look for a significant deepening of the normal ST depression in those anterior and septal leads. So this is about what you would normally expect to see with RVH. Take a look at your precordials. We have a little bit of ST depression and those inverted T waves. So this is actually concordant if you use the terminal deflection of the QRS. You see there's a terminal S wave. So in a strict sense, this is concordant depression and inversion. So in a way, you could say that's concerning, but this is not abnormal for RVH. It would not be unreasonable to get some precordial leads to reassure yourself, but you do often see this type of appearance. And otherwise, it's pretty straightforward. Same kind of deal as LVH, just in the other direction. Okay. Benign early repolarization, also known as maybe normal variant or J-point elevation. Some people think we shouldn't be calling this benign anymore because there is some evidence showing that these people have a very slightly increased chance of sudden cardiac death. But it is certainly common and is for the most part benign. Maybe the fourth most common according to that one study that we looked at. Really quite common in just the general healthy population. It's more common in young folks. As you get older, it becomes less common. The really classic population for this is young African-American males, especially athletic people. So it's really the opposite population we'd expect to have a heart attack. So as far as risk factors, that's certainly something you should be thinking about. The tricky thing is, this is quite common, and it's not real clear on the EKG, meaning there's nothing that will really jump out at you as defining early repol versus an MI. The good news is that although there are certain features it shares with your STEMIs, there's only a few things, and other than that, it shouldn't look like a heart attack. So what you will often see, some ST elevation, usually in the anterior precordials, maybe V2 through V5 or so, a little bit less common in the limb leads. There shouldn't be too much of it though. So often less than 1 or 2 millimeters, just a little bit of elevation, certainly less than, let's say, 5. And it should usually have that nice concave shape that we talked about. A convex ST segment is really pretty abnormal for early repol. And there's often this notching of the J-point, that fish hook you may see, which often is a pretty reassuring sign that what you're dealing with is benign and not an ischemic change. Now, less common findings, which are still okay, are pretty big T waves. Not huge, but enlarged, and you might call them hyperacute, with maybe a little bit of asymmetry. And you will sometimes see a little bit of variation or movement of the ST segment of the T wave when you do your serial 12 leads. And I know I'm saying that that's more of a characteristic of your MI, but sometimes there's a little bit of shift, and that's okay. However, other than those things, it should not look like an MI. So you shouldn't see any consistent reciprocal changes. You really shouldn't see a convex ST segment most of the time. There shouldn't be any Q waves unless for some reason this young healthy person had a heart attack 5 years ago. And although there may be some shifting, you shouldn't really see a consistent acute evolution. You shouldn't see everything getting worse. And there shouldn't be any clinical signs of a heart attack. Now, I'm not saying they can't have chest pain for some unrelated reason, but they shouldn't look like that classic heart attack patient. So a couple more little pearls. Usually, early repole is associated with nice, tall, well-developed R waves. So you should have good amplitudes in your QRS there. Why? Just like we talked about with LVH, an infarcting heart doesn't generate waves like that. It can't get those voltages. Early repole is a young, healthier heart. It should have nice, tall R waves. And it usually has a shortish QTC. Now, I'm not saying you should go and calculate QTs in here, but you can just look at the computer reading. It's usually pretty good with these. Longer QTs are associated more with ischemic changes. Now, Dr. Smith, of course, has developed a decision rule for this. This is pretty far up there in terms of obscureness. I would not try and calculate this unless you were a computer, but the general concept of a nicely developed R wave and maybe a longish or a shortish QTC for early repole, those are pretty easy. And his third criteria here is just that there should not be a whole lot of elevation, less than a couple millimeters. So this is a pretty typical early repole strip. You see we have pretty good sized T waves actually, and these are maybe more symmetrical than they often are, but at most maybe a little bit of elevation, not much at all. You see this little bit of notching around the J point in certain leads. That's very common. And you have nice R waves. Look at V4. That's maybe 14 millimeters. So this is a nice, typical strip for early repole. It should not jump out at you as being anything like a classic MI. All right. Ventricular rhythms. And by that I mean any rhythm that is in the ventricles. It could be paced. It could be even something like VTAC or a slower idioventricular rhythm. As we talked about, these are the only types of rhythms that I've actually had studies on them showing their validity for Sgarbossa. And these are people that we want to be able to read. I don't know how many times I've seen a medic say, well, he's got a pacemaker, we're not going to get anything out of that 12 lead anyway. But do people who have pacemakers have heart attacks? You bet. They've already demonstrated that they have problems with their heart. So we really want to be able to look past that and look for that potential STEMI. So again, usually the principles that we've already talked about, these can be tricky, but they are certainly workable. One caveat is that the traditional placement for these pacer leads, which is usually down in the right, an apex of the right ventricle, so down on the right side, we would say. A lot of modern pacers may not be following that pattern, especially the biventricular pacers, so they can do some funny things which may not fit all of these principles. But in general, use the same approach. So take a look at this one. This is a pretty interesting strip. This is AFib with actually a right bundle branch block. So you see, all right, let's look at maybe lead 3 here. There's maybe a little bit of concordant elevation. Lead 2, maybe a little bit as well. Maybe a little bit in AVF. And then in the interior leads, maybe a little bit of concordant depression and inverted T waves. So that's a little bit subtle though. However, take a look at here. We have a PVC. You can see it in all of in the 1, 2, 3 here. Look at this elevation. All right, we would expect some, but is it proportional? I would say no. That's quite a bit, maybe 4 or 5 millimeters of elevation. And compared to the depth of that S wave, that's really too much. Look at it in 2. It's almost the same amount of elevation as the depth of the S wave. That's much too much. That's disproportionate discordance. So this is really jumping out at us as showing how even these ventricular rhythms, even this single PVC should still follow these principles that we saw in the Sgarbossa method. And this is in fact a early inferior MI. Now take a look at this one. This is a paced rhythm. Same concepts here. Look at your inferior leads. Look how much elevation we have. A good few millimeters. That's way too much compared to the depth of the S wave here. Similar in lead 2, in lead AVF. Now look at AVL. That's probably too much depression for the size of that R wave. Look at your anterior leads. These are not too alarming maybe. But when you look at the overall pattern, we're again thinking, is there an inferior MI here? And yeah, there really is. So you don't want to be caught off guard by these paced rhythms. These people will still have the same problems everyone else does. All right, LVA, ventricular aneurysms. This is a confusing name. What is an aneurysm? Obviously, it's a weakening and a pouching of an area of tissue. When we talk about LVA, sometimes that is present, but really it's just a catch-all term for any persistent effects of an old MI, which can include an ST segment which never really resolves. It just stays elevated. Whether or not there's actually an aneurysm in there is beyond our area of interest. The tricky part is these can look very, very much like an acute MI because it was an acute MI, and not all of those changes will always resolve. So these can be tough. You will most often see these in the anterior leads, and the history will help you out here. Did this patient have a heart attack in the past? Now, that's not going to answer everything because you'll still have to look past that and see, is there another one going on right now? But you shouldn't be surprised by the fact that there are old changes on here. And if you can get an old EKG, again, very useful. Your biggest clues here, are there Q waves? This is an old infarct, so there should be nice big pathological Q waves from that previous MI. So the classic LVA strip has these big negative Q, or you can call it a QS wave, with maybe little to no R wave because you've just lost that from the damage. And despite that, there is no acute ischemia, so T waves should not be exaggerated at all. They shouldn't have any hyperacuity, and they shouldn't really be growing in that typical way. Now, of course, Dr. Smith has another rule for this, basically comparing the depth of the QS wave to the height of the T wave. Again, the first should be pretty big and the second should be pretty small. If it's more than about a third, then he says you should suspect MI. Again, I'm not going to tell you to go measure, but the principle has been validated. So this is a very classic LVA strip. Look at the depth of these Q waves. Very, very deep, very little R wave in there. But look at the height of the T wave and the amount of ST elevation. Not much at all. These are not exaggerated T waves. So when you see this, you should be thinking LVA. Just a deep plunging Q wave, not a big T wave. There's really nothing here that says any acute event. All right, pericarditis. This probably gets more attention than it should when we talk about ST elevation, I think because it's interesting. Not very common. We saw in that one study maybe 1% of patients had it. It's just an inflammation of the pericardial sac around the heart, often an infectious cause, but not always. So these can be younger patients who don't really have as many risk factors for MI. But clinical evaluation can actually help you a lot here. Traditionally, pericarditis chest pain is sharp, not dull or crushing, and pleuritic, so when you breathe it gets worse. It's alleviated when you sit up instead of lying down or even lean forward because it takes pressure off the heart. There may be signs of infection, so fever and that sort of thing. If you can appreciate it, there is often a friction rub over the heart, and not really something that improves with nitro or otherwise has those signs of ischemic cause, so not severely worsened with exertion or that sort of thing. On the EKG, traditionally it's got this diffuse, really non-localized elevation, so it's not like we're looking at anterior leads and it's elevated or the inferior leads. It's just sort of all over the place, except maybe V1 and AVR, which should go the other way. So they should have ST depression. There should not be nice consistent reciprocal changes. You shouldn't have anterior elevation and reciprocal inferior depression or vice versa, unless there's some other process which is confusing you in there. Often, but not always, there will be some PR depression. That's often what people associate with pericarditis. You may in fact see it. It's not always there, but when you do see it, it does support this. And in general, it can look a lot like BER. It just has a little bit of elevation with a nice concave shape. Often there is that notching in there, and often pretty good sized T waves. So approach it similarly. But your main clues for pericarditis are that really global elevation, maybe some PR depression, and otherwise nothing really that supports ACS, like reciprocal changes or an overall very poor impression. Just a reminder, pericarditis sort of evolves through different stages depending on the patient. Initially, there's often the elevation, which can normalize, and then later, maybe T-wave inversion, which can also normalize. So depending on when you get there, you may see different things. Pretty typical pericarditis strip. We have a more or less concave ST segment in most leads. You do see in V2 it is convex, which is not normal. That's a little bit strange. But other than that, we have nice R waves. We have a little bit of elevation, but not too much. And it's pretty diffuse. You see, V2, lead 2, AVL, a little bit of AVF, most of the anterior leads. It's all over the place. There's a little bit of PR depression in many leads. Look at lead 2 here. And look at AVR. You have ST depression. And you actually see PR elevation as well. Really the opposite from the rest of the leads here. So nothing here that jumps out as MI aside from that elevation, which we recognize as typical for pericarditis. Now, I will give one warning here. When you see global diffuse ST elevation like that, you may think pericarditis, you're probably right, but there is one other cause which can produce the same widespread elevation. And that's an occlusion of the left coronary artery, the left main before it bifurcates into the circumflex and the LAD, or acute three-vessel disease, meaning occlusion of really all three of the major arteries with some kind of acute deterioration of that. So in other words, practically the entire left ventricle is injured. That's why we see elevation everywhere. Now, this is a nasty disease. When you want to differentiate these two things, a couple tips. First of all, people with LCA occlusions look terrible. Really acute total occlusions, they will usually be dead before you get there. So often what you'll see instead of elevation is depression, fairly globally. But these patients look terribly sick. They may code on you if they haven't already. They will just jump out at you as being seriously ill and circling the drain. Pericarditis does not look like that. It is rarely that serious. And on the EKG, the tip here is AVR, the forgotten lead. These patients with LCA occlusions or the widespread three-vessel disease, they will often have some ST elevation in AVR. Remember, in pericarditis, there should be depression in AVR. If you see ST elevation in lead AVR with widespread changes otherwise in a poor clinical context, you should really start thinking about maybe a left main occlusion. There have been a few studies on this. Dr. Amalma, too, has really pushed the idea. It's not quite clear on how accurate this is. There is one study showing it may be as much as 80% predictive when you have elevation in AVR, which is greater than what you have in V1. Not everyone agrees on this, but when you have that whole picture, just a terrible looking patient with that AVR elevation and otherwise a lot of elevation or particularly global depression, you should really be concerned. Now, when you have that patient, I don't want you to just punt and go wherever. These patients need a facility that can give them emergent catheterization or bypass, and which one it's not fully agreed upon right now. But what is clear is that these patients do not benefit from thrombolytics. You can't just go wherever and they'll get TPA. That's not going to make it. These patients do not have the benefit in that case. The harm is greater than the benefit. They need to be cathed. Now, mortality for these people may be over 70%. These are tough patients. They may not do well no matter what. But try to recognize it early and get them to a facility with PCI. That's going to be their best chance. Certainly don't just say, well, it's pericarditis, they're okay.